Distal fragment go posterolaterally.
Lateral. It is a posterior medial or posterior lateral?
Posteromedial, sir.
Posterior medial.
Yes, sir.
Okay.
65-year-old female with intertrochanteric fracture of right femur.
Yes.
We have
Type
done 2.
Type
Wide
2.
and rapid type 2.
It looks like type 2 or it's gone off. It's looks like unstable and
Unstable, sir.
this is an unstable and
To hold the
we prevent the proximal migration to give better stability, and even for removal also to some extent it prevent the Z effect. So Z affected can be reverse Z effect and Z effect. So the Z effect comes into play when there is improper reduction, improper fixation and improper selection of the case. So to avoid this they are using the Inteltan, that is more of biological, biomechanical, stable construct. There is a newer generation for this to prevent this reverse Z effect and Z effect phenomena and all those things. And no, okay. So what about is it medial? Is it medial? Is it positive, neutral, negative?
neutral, sir.
Neutral. How do you say neutral? The medial cortex coming with the medial cortex of the proximal is continuous. In the positive,
It will be medial, sir.
it goes medially, positive medially. In negative it goes laterally. Laterally. So it is
Regional, sir.
regional. What regional?
Block, sir.
Brachial block. Is it? Okay. Regional block. Okay. Skeletal block. Okay.
So 64-year male with intertrochanteric fracture of left femur. So burden Griffith 2. We have done close reduction, internal fixation with short PFN for left femur.
See, still there is a moment of fracture,
Yes, sir.
gap.
Yes, sir.
So what to do? How to correct? What is the age of the patient?
64.
64. How do you correct the gap? How do you reduce anatomical reduction? Early weight bearing, delayed weight bearing. How do you reduce the gap? Early weight bearing, delayed weight bearing.
Early weight bearing.
Early weight bearing. Already fracture is unstable. If you go for early weight bearing, hardware problem generate.
Yes, sir.
So you have to wait from 6 weeks to 3 months also in these cases. Otherwise they come with all Z effects and hardware problems.
Okay, sir.
You should be very, very careful. Well taken point. Yes, sir. Go ahead. When there is no anatomical reduction, you should not go for early weight bearing. That is a fundamental principle. क्या विशाल साहब? क्या है सर? Yes, Mansalam.
Year-old female with closed lateral and posterior malleolar fracture of left ankle, sir. These are the CT films, sir.
Clinical photograph. See, is the abrasion injury or open injury?
No, sir. Those are bleps, sir.
Bleps due to what?
Compartment.
Bleps due to what?
Impending compartment, sir.
Impending compartment. It is a closed injury. It's not an open fracture.
Not an open, closed, sir.
So there is a lateral malleus and posterior malleus.
Yes, sir.
So which ankle? Left ankle? Right ankle?
Left, sir.
What is the age of 28 years? What is the mechanism of injury?
Twisting injury, sir. Twisting injury.
Mask then, sir.
Twisting injury.
Twisting injury of ankle, sir.
Twisting injury. Venkatesha Prasadama. Mama Venkatesha.
These are the CT films, sir.
They call it as a twisting injury, or you have to have specific supination, external rotation, చెప్పాలి. Twisting injury to ఏమని?
Okay, sir.
అది ఏం ఇంజరీ చెప్పు మరి. Go back.
Supination, external rotation.
What injury is this? You said lateral, posterior. Where it is common?
Supination, external rotation. Yes, sir.
He came like that.
Yeah, she came like this. Yes, sir.
You not remove the socks and see.
Ankle, no, sir.
But the socks are there with the patient. You not remove the socks and see. So what point in showing this like that? Huh?
Proximally, it was normal.
No, why you want to show that picture? Why you want to say? Is anything specific?
No, sir, those were blips, sir. It was a.
Okay, but there is discolored. Is there socks there?
No, sir.
No,
What is that?
those are blips, sir, post admission.
Looks correct, eh?
We are not able to understand what is that picture at all. We are seeing the ankle foot with some blood staining on the.
Right? Skin.
Yes, sir. Talking, sir.
Something. అదే చెప్తున్నా సాక్స్ అని చెప్తున్నా నేను కూడా
చెప్పడమే సాక్స్ కాదు, అది పైది ప్యాంట్ అని చెప్పాలి కదా.
సాక్స్ అంటే
అదే
అది కాదు సార్,
అంత వైట్ ఉందాక
పైది నాలుగు ప్యాంట్,
పైన ప్యాంట్ సార్,
కింద కాలే కదా. రైట్. ఇట్ లుక్స్ యాజ్ వాట్ ఐ మీన్ టు సే.
We have done supination extra rotation.
classify the injury according to lag hamstring.
Supination extra rotation.
Huh?
Supination extra rotation. Supination extra rotation.
Supination means what? Is it adduction type or abduction type now? Adduction or abduction ఆడుతుంది నేను.
Adduction type.
Adduction. Adduction type. The gap is there, but still. Which are the?
Medial joint space of the ankle is increased, sir.
So is it abduction or adduction now?
Sir?
Medial joint space increased now.
Yes, sir.
The foot has gone abduction or adduction now?
Adduction it has gone, sir.
Adduction.
Yes.
Adduction how?
Talus has gone into little bit of.
Talus has moved towards lateral side. Lateral side.
Yes, sir.
The gap on the medial side. So where is this now? Is abduction or adduction now?
Abduction.
Abduction or no? Adduction has come way up to that. Without knowing all these things, just putting is not enough.
And do you expect the deltoid ligament tear here in this case? Because
Yes.
the medial joint space is significantly widened. We have to also look at syndesmotic injury. Is it suprasyndesmotic, infrasyndesmotic, or transsyndesmotic?
Lateral malleus fracture is there. Yes.
Suprasyndesmotic.
Is it spiral? Torsional.
Rotation.
Torsional malleus. To rotation.
Whether it needs fixation or
Yes, it is.
to be treated conservatively. What are the guidelines?
More than 25% the size of.
Think of all these parameters.
Yes.
You have to describe that before putting the test of
Okay.
you rule out the deltoid ligament injury. How do you suspect?
Unless you take MRI. Just X-rays and MRI.
The gap is getting widened further. We expect that the delta is a partial tear or a full thickness. Full thickness is superficial and deep composite.
Yes.
If it is grossly unstable, that means we have to neutralize the repair also. Minor tear, superficial tear, they heal. Immobilization.
First element to give way is medial side. It can be ligament or it can be fracture medial malleus. Then this talus moves towards the lateral side, itching against the lateral malleus. Then fracture is there. Then torsion is there. Then produce posterior malleus fracture. This is what the mechanism is.
Okay.
Simple to explain, right?
Yes.
Right.
We have done open reduction internal fixation with plating.
Piping.
No, sir. Posterior malleolus extension is there into incisura, sir, but tibial pylon is not involved, sir. Yes, sir.
Posterior malleus, is it a big chunk or it has a two divisions you can make out? How many? Is it lateral part and medial part which has gone? So what I'm taking, I mean, CT scan and MRI only, no? Yes. So lot of things are in this. Posterior side. That's what it looks like.
More than 25%. More than 25%.
More than 20. Minimum. No, now the trend is whatever it is, you have to fix it. Whether it's small or big, doesn't matter. Along with that, they have ligaments, posterior side ligaments are there. That has to be fixed. The best thing is to fix. Right. That only shows. Yeah. Can make out right.
Sir, they have told that fish posterior malleolus, then lateral malleolus. If it is not possible, first fix lateral malleolus, then posterior malleolus.
Does it make any difference now? We are putting lateral medial. You can reach the posterior side along with the lateral malleus. With one approach, can you do both or not?
Yes, sir, we can do.
That's what-
Posterolateral approach to the ankle joint.
Right. So what have you done?
We have done plating for lateral malleolus and posterior malleolus.
With one incision?
Sir? Yes, sir. With
Posterior
one
side?
incision only.
Show the incision.
Photo is not there, sir.
మరి ఎలా ఉందో వచ్చి You satisfied? Posterior malleus
Yes,
well,
sir.
well fixed? Posterior anterior, not anteposterior.
No, no, sir. From posterior to anterior.
Right. Okay.
Yes, sir. I have. Posterior, they are fixed. Yes, sir. Sir, for posterior malleoli, we have used 1/3 tubular plate, sir. 5-hole 1/3 tubular plate. And for lateral malleolus, we have used locking plate, sir. Not recon, sir. Locking plate. Pre-contoured locking plate, sir.
Right.
No, sir.
Years old female with 5 days old intracapsular fracture of left femur, subcapital type, sir.
Right.
We have done cemented
Okay.
hemiarthroplasty with AMB.
Okay. You're not aware. So is that? That's all right.
35-year-old male with closed
the-
distal third shaft.
First X-ray, AMP X-ray, right? Now this. So what is this?
Sir, subcapital type IC
Hmm.
fracture. subcapital type, sir. We have done cemented hemiarthroplasty with AMB, sir.
Why?
Actually, bipolar process were some other company, sir.
Oh, did you
It was
No,
broader.
did you template
Sir?
before doing surgery?
Yes, sir. Yes, sir.
Template?
Yes, sir.
You don't template also?
Yes,
Ekkada?
First we had kept Astenmore process, sir. It's fine.
I am asking template. Prior to surgery, you have to say templating is to be done. We are not doing it regularly. The problem comes when doing surgery there only. Templating is not done. You face a lot of problem doing surgery. That's what happens. You know. So what happened here? Do you plan for AMP or do you plan for a
Actually,
bipolar?
we planned for bipolar, sir.
Hmm.
But the company was different from previous one, sir.
Hmm.
The collar was broader and
But which collar? The AMP broader or
no,
that
sir,
broader?
the bipolar process collar was broader, sir. It was not
Normally,
fitting.
if you see, this is the collar which is the AMP is broader here,
Yes,
not the bipolar one.
and it was in rectangular shape, sir, not as a pre-contour.
Hmm.
That's why.
So you have chosen
It
only
does not
AMP.
fit well, sir. That's why we had. Yes, sir. It was not going in. Yes, sir. Unable to. Yes, sir. That's why for no option available. That's why.
What was the size you have put?
41, sir.
41. It looks a little big. Or 39.
41.
So it went on smoothly
Yes,
without any problem.
Sir.
You didn't have any problem?
No, sir.
No.
Yes, sir.
Mhm.
9.
Yes. Small only.
Yes, sir. We have checked the range.
35-year-old male with
Yeah. How much is the size? Looks like the TK, I mean, yeah, so by measurement. Template is not there. Yes. Mm. Not this. 10%. 10%, right. And then select it. Whichever fits in. Okay. On. Safe, on.
We have
Once it. That only for trial thing. Trial process is there, can do that. Trial is always very difficult to do it. But only thing is once you put it inside, the suction effect is there as it goes inside. Suck. That's what the exact size. But is the cement used here?
Cemented, sir.
Or proximally it's there? It's not there. Distal convert. Is calcar is there or split? Calcar is split now. Huh? Chupra. Not harder. Size first. First X-ray. Prior. Now to see this, how much is calcar there? It's quite good. We are a little more. They have cut it a little more. I think it's gone inside. Okay, it may sink. It may sink down. Right. They are own. The outside. It cannot. To know the different triangles in it. What triangles are there? You can make out in this. చూడరా అక్కడ yes that can be seen there. Which is major one to say big triangle is there? Right?
Weight bearing area.
Weight bearing, huh? That what triangle is where deficient bone is not there, just fat is there. That one. Right, Tulchu? So this is the area which is completely empty here, beyond 70. So this triangle forms a what triangle? So this triangle forms Babcock's triangle. Unless you take perfect X, they can't make out. Yeah. That's what they used to say. One time, not now. Now it can say right. Yeah, teaching, yeah. Yes. Teach. Right. You should know these triangles. Is it restored now? Mechanics of the joint? Offset, vertical and horizontal offset? Restored. Huh? You have seen on table.
Yes, sir, we had seen the limb.
Did you?
No limb.
Yes, sir, no limb line discrepancy.
Discrepancy.
No, sir. We had checked, sir, for rotational. Sir.
Right. Right.
35
Okay.
mil with
All. You are a trouble, no? Right.
35-year-old male with closed distal end shaft fracture of the right humerus. We've done open reduction internal fixation with plating for the right humerus by posterior approach.
What about the nerves?
So the ulnar nerve was protected, sir. Radial nerve and
Is that DNVD problem?
there's no DNVD.
ప్రధాని DNVD
There's
ఎత్తలేదు
no
అసలు.
DNVD.
No. No.
So radial nerve entrapment can occur in fragments. Spiral due to if there is any injury of the spiral groove, if there is any injury to the spiral.
Icke spiral groove, not here. This is not spiral groove. What is Salson-Levy syndrome?
Yes, sir. Entrapment of the radial nerve in
Where?
the upper.
Yeah, unless you know the course of the, now you can't say this thing. From posterior to anterior, it comes through the lateral nervous septum. From there it gets tethered. Because of this lateral angulation, it can produce. Now, if the lateral angulation is more, every chance of getting a radial nerve palsy. Angle is not that much, don't escape. Not all fractures, involvement no. Only if it is lateral angulation is more, then the chance of getting a radial nerve palsy is there. Otherwise, no.
Radial nerve. Upper.
Right. What approach you have gone?
Sir, posterior approach. Triceps splitting.
Right. Go. It will take long time again. Nick both again. The risk of fracture again. Very mean. Fracture side.
Yes, sir. Yes, sir.
Right.
Yes, sir. No, sir. 3.
Upper limb proximal 3 and distal 3 we will take, sir. In lower limb.
Got.
Yes, sir.
ఇది ఫస్ట్ నైలింగ్ తర్వాత కదా ఫస్ట్ ఇది ఫస్ట్ యూనిట్ రైట్
No, 23-year-old male with closed middle third, distal third, shaft fracture of left femur, sir. We have done close reduction with interlocking nail for left femur, sir.
What about fragment?
Butterfly fragment, sir.
Yes, it will come nearer or not? The chance of union is there. You didn't open this at all, right? Did you open this area?
We have opened it.
Then why it's still?
We have opened it and tried to push the fragment, sir, but it was not holding, so we have just left it to
Like that. So chance of union? After that?
Yes, sir. We were able to nail it. No, sir. Nail, sir. Little bit more, sir. Just we tried to push it.
Chance or any statement can push it inside. First. Chance of union is there?
Yes, sir.
Very good chance is there?
Yes.
How? Yes. Why do you say it is there? You can't say. This may not come near surgery also.
Usually butterfly fragment, if present, it will heal.
So if you disturb the fragment, disturbing it will not have. So you can't say. You can fix it. Well, God only knows what happened then. Right.
A 47-year-old male with intertrochanteric fracture of left femur, Boyden Griffin type 2, sir. We've done close reduction with proximal femoral.
Intertrochanteric idi besa. It's intact this year.
It's intact, sir.
Fracture line is like this, right?
It is from the, you can call it paratrochanteric fracture.
Basal kada idi.
Sir, GT is involved, sir.
See, paratrochanteric starts from here. Paratrochanteric is from here to here, paratrochanteric, right?
Yes, sir.
Or this base only? You can see it. Lateral view చూడు ఏది ఏం lateral view లో
Yes, sir, లేదు సార్. GT
అదే ఇది 10 normal. Okay, what have you planned for this?
Sir, we've done closed reduction, internal fixation with proximal femoral nails.
Not the plate. DHS was ideal for this.
Yes, sir.
Then lateral wall is very good, undisturbed. Yeah. Okay.
Slightly positive. "51-year-old male with intertrochanteric fracture of right femur, Boyd and Griffin type 2, sir. We've done closed reduction with PFN with washers."
Was it easy to get reduction, close reduction?
No, sir.
No, then? Did you open it?
No, we didn't open it, sir.
It
From
is-
outside we pushed
You open the fracture site here. You are making, otherwise not come. We tried close reduction,
Yes, sir.
then open it here so that fragment is pulled inside. That's what is it.
Yes, sir.
Yes. Just to reduce it, right? Yeah.
Yes, sir. Yes. We opened.
చేసింది చెప్పలేరు.
Yes.
Yeah. You could get it nicely. అదే. Next.
51.
ಹೆಂಗೆ ಅಲ್ಲಿ?
54-year-old female with closed middle third, distal third junction shaft fracture of the left femur, sir. We've done closed reduction with it's a transverse. It's a transverse fracture.
Transverse fracture it is. Now short oblique. Is it?
Short oblique.
Is it short oblique or transverse? Short oblique only.
Short oblique. Oblique. Transverse fracture.
Remaining part.
Stable.
You want to make him walk? Next day, can he walk?
She can walk, sir. But
Yes.
In this case, we are put her on non-weight bearing
Tortoise
because...
can be done. The fixation is stable, no? What is there?
Yes, sir. It can be done, sir, but this is also plastic surgery.
Eight.
Yes, sir. We put 9 size nails, sir.
It looks very, very narrow.
Yes, sir.
Age 54 years now. Okay.
Yes, sir.
Thick. What is the nail size?
9, sir.
9.
9.
Problem.
Yes, sir. We saw the... Sir, laser, we saw the canal was narrow. Yes, sir.
Right.
8. మన దగ్గర 8.
Child. ఉంది రీమర్ ఉంది. కూర్చో. ఉంది. ఉంది. ఎప్పుడో వచ్చా? Yeah. Yes.
Color of the nail. It is black in color
White
and
is
color Siam in the Siam
Black
the
is black,
nail
sir.
appears black.
Because it's white here, black here. Yeah. Right. Okay.
Why the bone is white
White.
in the X-ray? Why is it black on the CM?
See, I'm definitely
I appreciate your presence of mind.
black and white. Black and white is there, but white.
The conventional X-ray is a negative film, like a negative of a erstwhile photon
Yeah.
film. The CM picture is
Different.
a positive one.
Yes, sir. Yes, sir.
That's the color difference.
Do you know that? Except black and white.
Right.
The hair is black in the X-ray.
Yes, sir.
Asal point చెప్పలేదు నేను. On the CM there is a gap of
That's got
nearly
reduced.
2 mm.
Yes, sir.
So after the nailing, the gap has been reduced.
How did you?
So
damage-
before applying the distal locking screws, we've
What did you do?
docking.
How?
We
From towards knee.
we pushed it. So we released the traction and we pushed the.
Just push it with the hand.
After releasing the
That's it.
traction, we released the traction, sir. We released.
Just by releasing it has gone.
No, sir.
What is
no,
the
but
function?
We also.
Where did you
Like
thump?
On the heels.
some
On
heel.
the heel. Can it
Or the
go
knee.
and transmit right up to the fracture?
At the knee,
No,
you
sir.
can
We
do no.
held the distal thigh and we.
Flex the knee
Flex the
and
knee.
thump. Not on the heel. It cannot get transmitted so long.
Yes.
The traction is
Usually
there.
that also fails. Unless the medullary canal is very wide. What is the best way? How to? This point has already been discussed
Yeah, yeah.
several times. Do the distal locking, don't lock the proximal one. And then take a, what is that?
Ramrod.
Ram rod.
What is
Ramrod.
that?
Mallet.
No, no.
It is not extractor.
Impact.
It is not called as it is the impactor also.
Ramrod.
Huh?
Ramrod.
Ramrod. It is called as a slotted hammer.
That's
Slotted
different.
hammer. You have to
Slot.
take it and try to pull the nail out.
Then it.
Yes.
Okay.
Right, right.
This looks almost a transverse fracture.
Yes, sir.
You can bear them very early.
Yes, sir.
Okay.
Retention, then fixation. So directly you go for freehand technique interlocking, you get a gap. Because the muscle forces are deforming forces in the femoral segment. So the muscle power is more than the bone power in the femoral segment compared to the leg segment.
Yes.
In the leg segment, the bone power is more than the muscle power. So the fatigue fractures also very high in femoral segment compared to the tibial segment.
75-year-old female with intertrochanteric fracture of the left femur, sir. Boyd and Griffin type 2. Then closed reduction with PFN for the left femur.
Next.
49 male with 14 weeks old, post-op comminuted both bone fracture of the right leg with fibula plate and bone cement in situ. He was first a compound fracture, sir, grade 3B, for which X-fix was done and removed 14 weeks ago.
You have used antibiotic bone cement.
Yes, sir, antibiotic impregnated bone
When
cement.
was it removed?
It was removed after 8 weeks, sir, of applying the X-fix. So now we've done open reduction with dentamycin impregnated bone.
Okay, what is the skin condition?
Sir, now the now the wound is healed, sir. There's some scabbing there. Yes, sir.
Is there a full thickness flap or not? That matters. Or
Yes,
is
sir.
the skin adherent to the bone?
The skin wasn't not adherent to the bones.
Looks like full thickness
Hmm.
flap.
But not healthy.
Yes, sir. That's not. We've done open reduction internal fixation with 4.5 mm locking recon plate, sir, for the right tibia, and we also put a tricortical graft from the iliac crest and put a screw through it, sir, for additional stability.
So there are 3 procedures done now. Huh?
Yes, sir. Sir?
Night?
Yes, sir. It will unite.
Optimistic.
Yes.
Because
Will
of
unite, sir.
dicortical graft.
Go to the first slide, sir. So what do you call that frame? What do you call that frame?
Delta
It's a
frame.
fixed. The name of the excel it's a pyramid.
Delta frame.
Delta frame. Get it upon.
Delta frame, sir. 42-year-old female with 1-year-old malunited distal and radius fracture, sir. There is a manus valgus deformity. The patient came with complaints of ulnar-sided wrist pain and restriction of daily activities. So,
She came only for the pain on the ulnar side. That's all, nothing else she had. Not worried about the deformity. She able to do it. Movements restricted. The main thing was ulnar sided pain.
Wrist pain,
Or
yes.
the ulnar head. Otherwise, so all these complaints are only the ulnar side pain only. Because of this
lifting weights.
malunited one.
Yes.
She unable to work. She's a laborer, is it?
Yes, sir.
She's a laborer,
Yes,
right?
sir.
Dominant
No,
Yes,
right.
sir.
Is a problem in dorsiflexion of the wrist. Okay. In power grip, you need dorsiflexion of the wrist.
Yes, sir.
So prominent ulnar impinges.
Yes, sir.
Power grip is not there.
Your extensor pulse is longus also plays a great role. Extensors are important.
Yes, sir.
So your X-ray should be in anatomical position. What about the clinical picture?
This is what the picture
On
is.
the table.
But did you focus on this ulnar head? Is it more
Yes, sir.
prominent?
There's
seen on
positive
top?
variance.
What are the
Yeah.
else?
positive. And if you take a lateral view of the limb, you show the dinner for deformity.
And the deformity is not that much. Problem is this.
There is a 15-degree angulation.
Angulation only, but she's worried about this area only.
Yes, sir.
Right.
Pain, ulnar
No,
pain.
ulnar. What are the causes of ulnar side pain?
Sir?
Ulnar sided pain. What are the causes?
The TFCC impingement. No, no, sir.
It's a 1-year-old.
When you have only pain on the ulnar side, that's all. There are many conditions.
Complex regional pains. Pains.
Where- So what's the problem? What's the problem? What she has come for the deformity she has come or for the pain she has come?
Pain, sir. Mainly pain.
Pain only,
Ulnar-sided
that's all.
pain.
She's not worried about the deformity.
She also has.
Function is normal. Wrist function, upper limb.
Yes, sir.
True.
No, sir. No, sir, she does not have any.
How did you say it's not there?
How do you know it is CRPS?
Complex regional pain syndrome.
Location of the pain. Location of the pain. The whole hand and fingers will be painful. The skin will be
Shining.
Shine. Swollen.
Shiny with loss of hair. But it's not there, right? I know.
paresthesia. Pain can be intractable. All reasons are there.
Both are same. Pseudex arthrodystrophy and this is both are same. Same. No difference.
Yes.
Shoulder hand syndrome. What is it? Shoulder hand syndrome. That means function of the upper limb. Normal unda. Shoulder movement unda. Elbow unda.
Shoulder movement
That's
was
what.
normal.
Okay, right.
ఇందాకేమో నేను చూడలేదని చెప్పాను. Within 1 minute to contradictory answers.
The pain is disproportionate to the clinical. You cannot touch, you cannot do. They will shout like anything. I've seen CRPS case.
That's cause. That's what causology. Causology is that answer. Yeah.
Female. sir.
Female.
What causes pain?
Looks simple, but you said no color. So same color holds good there.
Okay. So what did you plan for this?
Sir, we've done Dirac procedure for the ulna and corrective osteotomy of the radius, sir.
Why?
correct the deformity, sir.
If the patient has only pain on ulnar side, treatment of choice is Darax procedure.
She was unhappy with the deformity also, sir. So we
Yes, sir.
corrected
Okay.
it.
What years? 45?
42, sir.
It will improve. When you
She'll
remove
be-
this part, it has to improve. Movements are there. Adhe also. Starting right. No, no, if you see the angulation here, this angulation not 15 degrees is there.
Yes, sir. Yes, sir.
Right.
Yes, sir.
Okay. Correction is done or not?
Yes, sir.
Deformity is corrected.
Radius has been corrected.
Mm.
Yes, sir.
Mm. That's enough, no? Not much. All at least is there. But only thing is now, you see this. Prior to, anta. Doesn't matter. 6 you have to attend. 6.
5 degrees dorsal.
But clinical picture show on the table.
On table. Yes, sir.
Plate is second surgery, horrible. No, again, plate removal is more surgery. The best thing is to put a caver that's fixed. Caver is stable only.
Petals and yeah, per-up, intra-up, post-up, follow-up. Sir? Yes, sir. There is laborer.
Patient has asked for correction of the deformity or we have suggested?
She came only for pain, sir.
She came with pain. Sir.
Only pain, she was worried. I said, okay, do that along with that. Anyway, you're opening that area. I can easy to put a osteotomy also. Right. Yeah.
Yes, sir.
Mm-hmm.
Sir?
Where? This is okay, but this much is enough. We have put it. No, plaster they applied in the wrong way. That's the plaster would have made here. Towards the ulna. This gap is there.
Gap is
Ulna division పెట్టాల్సింది. Plaster వేసినప్పుడు. Palm flexion doesn't matter. You can't do this. Cast index only in forearm fractures, not in this elbow.
Sir,
Here, no.
lateral view of inner diameter excluding the pad
That's
with AP.
that fellow's thesis also. Right. That's only for forearm fractures, not the wrist. Right.
Yes, sir.
Finished? Right.
Good morning, sir. These are the cases done in Unit 2. A 35-year-old male with 2 months old non-union of distal third fracture of right tibia, sir. 2 months back, he was sustained injury and X-fix was applied elsewhere, sir. 1 month later, it was removed. We have done ORF with plating and bone grafting. Yes. Yes. This is at present, sir. This last.
Earlier it was put only this X-ray, right?
Yes, sir.
So that, this is the,
This is the recent X-ray, sir. When he presented to us, sir.
so what you have done, is it united now?
No, sir.
Fracture united?
No, sir.
How do you say no? More than that.
Delayed union.
But radiologically, do you say non-union or not? Or delayed union? What is this? Do you get non-union in metaphyseal areas? Non-union is common here.
Malunion.
She has not seen.
No, sir, there is abnormal mobility.
You will not get it. So how to make out? How to make out a single non-union? X-rays are doubtful, clinical doubtful. How to make out is a non-union? Only one test. Two bones are there, forearm as well as leg, right? One bone is fractured, one is not fractured, one is about to unite. How to make out is not united clinically, not X-rays. Spring test. Squeeze the proximal or distal one, you can set pain in that area. That is a squeeze test. Either for leg as well as the forearm. Single bone, spring. One part you hold, squeeze it, other part gets pain. That's called spring test. That's what you should do. This is both bones, forearm as well as both bones, leg. Single bone. Probably. X-ray may not seen sometimes. Very difficult to see in X-rays also. So best thing is delayed union is there. Squeeze the proximal part so that the pain we feel at that fracture area. That is called spring test.
Can you have a trial with fermientoplasty for this case? Spiral fracture extending into the joint. Muscular comminution.
Joint, I think, a bit difficult in fermientoplasty. Is it possible?
Yes.
So you can't have a conservative match.
Yeah, I think probably. The screws are in the joint. Screws in the joint as well as in the fracture site. Not in the. Probably size of the plate also not appropriate. Go to the pre-op. Always, whenever you're presenting, final X-ray, this one and the copy this one. Copy. No. Yes, copy that one. Go back. Paste it in that post-op X-ray. Where is the final? Paste it here. Expand it. Put this one. Look at me. Put this one here and this one here. More. Now, what's that? 5 minutes. Yeah. Your X-rays, everything, pre-post. Because our memory is short. You can't recollect what was there and compare with this one. Now it's very clear, isn't it? That's how you do presentation. Very good. So the who is Rajshekar, your unit? I think there is a fracture here, is it? one fracture there, and it's that one is there. Probably would have been, but did you should have tried one screw, just a screw normal, because Herbert screw not going to hold here. Herbert screw, because it needs compression here. So one with the reduction, screw across, and maybe not too big. The plate is too big for this. Is the distal femur plate or is the medial tibial plate only? No. You can't, that's only. That's not the answer. You can't have available plate. You can't use this for a finger. Saying that's only plate available. Use an armor DCP plate. Contour it. This is inappropriate plate for the fracture, and the reduction is not. See, whenever you do these things, for you, all of you, you reduce temporarily. The whole idea is reduction of the articular fragments with KYs. Then fixation with screws, 1 or 2 screw. Then this fragment. That's the principle of intra-articular fractures with the diaphyseal extension. And this is not a, because you have to have, there is no fixation on the medium, on the lateral side. No stability. As Anjanelu, Dr. Anjanelu said, Sarmento would have been better than this fixation. Okay, we had to discuss, we'll discuss this one later. Okay, go on. Which one? But that one, see, you can easily put a screw here. Yeah, this one. And you can put a screw across there. I know it's a 3D fracture. Difficult one, very difficult one. But you should use why did you use Herbert screw? Huh? No, why do you use why not use a cancellous with a washer? Herbert screw does not give compression for this kind of fractures. It only gives for intra-articular fractures. Little lag effect. It's not. It doesn't give compression. Though the partially threaded cancellous screw. Look.
31-year-old male with 3 months old non-union of proximal third, middle third junction shaft of tibia and distal third shaft fracture of fibula of left leg, sir. This was initial injury, immediate post-op, and this is at present we have done no.
Go back. What is the duration?
3 months.
3 months. Immediate post. At present, you put a duration here, easy.
We have done ORF with ILN and bone grafting.
Okay, that's I think acceptable probably. You say surgery is not required. Dr. Jadishwar, go back. But this is. This kind of X-fix, I think probably. So better, don't wait. Wait till wound is healed. Don't wait 3 months. You can't expect, as Dr. Anjali said, you can't expect for the fractures to unite with this kind of fixator, unless it is Ortho fix or Ilizaro. Okay.
35-year-old male with subtrochanteric fracture of left femur. Such a long distal fragment, the whole of the distal fragment is attached by the adductors. So much of adductor force is acting at the fracture site, and the lateral column there is no continuity, and that instability at the fracture site is going to enhance the mechanical movement abnormal mobility, and the abductors keep pulling the proximal fragment away. So there are two opposing forces, abductors and adductors are two opposing forces. Okay, so it's, and the gap is quite large, and the fragment has not been getting into contact with the major chunk of the fragment.
See, the whole idea of fracture fixation, especially in this area, opposing the forces which are distracting, neutralizing. That's what Dr. Anjanil said. Unless keeping the deformity. So the whole idea is forces should be neutralized. I know this is also difficult, subtractant fracture, but the whole idea is you have to neutralize. Then only implant will work.
Plate.
We will have a discussion altogether. Not. I think this. Reduce it properly. You already opened. See, this is too much abduction, and what happens is angulation. Both. See, you are supporting the opposing forces. You're not neutralized. The whole idea is neutralization of the deforming forces. You must neutralize, then only implant will work. Otherwise, it will fail.
Entry point.
Yeah. But you must correct it. You must correct it. The entry point, when you take entry point, go back. Entry point, where should be the entry point? Any senior resident? Ahmed, you come. You're hiding. Go to the board, because this is the most important point. Show me the entry point for here. Providing a normal. Go to the board. Take the point right away. Here. How would you decide entry point? This is a common mistake everybody does. Happens time and again. Where do you make entry point? Medial? What are the factors which will decide entry point? You've done some nailings? Yes.
Medial to tip of the greater trochanter, we have to take entry in PFN, sir. But because it's designed in such a way, it's a bowing. So if we take a bit lateral entry, we won't achieve any reduction, sir. So in that. Sir?
Have a lateral entry, why you cannot get a correct reduction?
It won't correspond to the medullary canal, sir.
So tell me two factors based on which you decide the entry point. Give me the pointer. What are the two factors? Because there is no point in doing just nailing, 100 nailings without knowing the basic principles. What are the factors which you will decide the entry point? Two factors. Tell me only two factors.
Type of fracture.
Fracture is always any type of fracture. You can't. Entry point is lateral. Where it enters, comes out. That's entry point. Understood? Can you repeat it?
Depending on the design of the nail, we should take the entry and it should correspond both in the API.
Guide wire, you pass cannulated all. Understood?
Yes,
not a big guide wire, a small guide wire. Extends up to there.
Yes,
all. And open up this mouth, bigger mouth. Then pass the guide wire. Then you ream it. But you don't do most of the time. You just make an entry point and pass the guide wire.
Yes.
That's why you end up in trouble. And you end up like the nail we have done. I've seen most of the nails. Most of the time entry point is not. Entry point is the extension of the medullary canal, both in and AP lateral. Basic principle. Unless it's straight, because most of the nails are straight. So if it is not straight, it won't go in. It will hitch on the medial side or posterior side. And you break most of the time. Okay, show me the next one. Go back. So here, what happened? Show me the X-ray. So here the entry point is where? It's not a corresponding. That's why the deformity remained. If it is at the exit point of the medullary canal, both in AP lateral, fracture automatically reduces. No point in reducing the fracture after making entry point and putting a nail. You cannot achieve that.
Intraoperatively, because the fragment is very short, proximal fragment, it wobbles. Yes. It will not allow you to put the so-called awl for entry point. It keeps on moving. If it is a very long proximal fragment, it will be quite stable. And because of that, you are probably not able to put it in the desired position for the entry of the guide wire. No, గైడ్ వైర్ వేసిన తర్వాత ముందే ఓపెన్ చేశారా సో ప్లేట్ ఆగ్మెంటేషన్
Entry point is not right. Reduction is not right. Unless you are happy with the reduction, you should not pass guide wire. You should not scrub unless you get the reduction. You get the reduction, but it displaces. That's okay. You could have passed. Yes. Retrograde nailing, yes, very much. Absolutely. So the basic principle, that is the basic principle. The line should be straight. Then only fracture automatically reduces. Next. Done.
Yes, done. Done.
Direct injury. Fall on the steps. No operations. Renika Chaudhary Valla. I should not say on this one. AP, skyline view.
Norway, and study duration is from January 2016 to 2021 February, and the sample size is 39. Total patients taken with multi-ligament knee inclusion criteria in the study is acute grade 3 PLC injury and underwent concurrent ligament repair and reconstruction. Exclusion criteria are if there is no PLC injury and inadequate MRI sequences, T2 weighted fat suppressed, and MRI sequences available in both coronal and sagittal planes. MRI done more than 30 days ago after the injury. And data sources, medical records, MRI and intraoperative findings recorded. Demographics and injury mechanisms, high, low and ultra low energy. PLC structures involved were laterocollateral ligament, popliteus tendon and bicep femoris. Ligament tear location proximal, mid-substance and distal. Associated injuries were ACL, PCL, meniscus and cartilage injuries. And peroneal nerve status, partial or complete palsy. MRI is T2 fat suppressed, used to classify bone bruise location anterior-laterally, posterior-medially and posterior-laterally. Yes, sir. Injury pattern in this ACL and PCL with PLC is 14, sir. And ACL and PLC is 22 in 22 patients, and then ACL, PCL and PLC with MCL is 1, sir. And
what is your conclusion from the table? Why Sridhar asks you to read the table?
This is usually with multi-ligament. I don't know.
You don't know. That's a good answer. Commonly missed. We see it's only ACL injury, but you miss PLC. You understood? So commonly, as all ACL injuries, if there is instability after ACL reconstruction, you must consider PLC reconstruction. Repeat the sentence what I said.
Usually in ACL injuries, PLC is missed.
Not usually.
Yes. In ACL injuries, PLC
More
is
common in ACL injuries.
Yes.
Okay.
It is missed, sir.
Oh.
So after the reconstruction, if it is if the knee is not stabilizing properly, we need to consider PLC. Sir.
Not stabilizing. If ACL reconstruction, if knee is unstable, then
We have to consider PLC.
How many times you read the journal?
I read, sir.
How many times?
Maybe 3-4 times more than that.
The maybe means you are not read. Maybe once or twice.
No, sir, I read. Easily 3-4 times I read. What, sir?
Clinically, what is the test that we do?
For PLC, sir. Dial test, sir.
Okay.
So that is the logic here that every ACL doesn't just. So it is very rare that with ACL and PLC association is so high. Normally with PCL, every surgeon will check for a PLC because that has to be ruled out. But with an isolated ACL, that PCL being is such a high percentage.
Yes, very high.
Most of these injuries are missed out. Many people don't even diagnose that. They are very less in incidence. Otherwise, any more motorbike accident.
FCL tear, it is 33, sir. And in proximal, it is 6. And popliteal femoral avulsion, it is 22. And biceps femoris avulsion is 26, sir. And associated intra-articular injuries. Study limited generalizability, popliteofemoral ligament not reliably assessed, and no randomization, descriptive analysis only, no statistical correlating.
It is eye opener for everybody, isn't it? Eye opener that we think about it. So can we assign a work for you? Make a chart, a nice chart. Sit with Ravi.